All right. So, just by way of introduction, my name is Dr. Bacus, and I'm the founder of Alivia, founder and director. I'm a bariatric GP, and I love my work, and I love working with many of you who are here tonight. I'm also the immediate past chair of our RACGP specific interest group around obesity management, which just involves setting policies and directions for how we can help patients living with obesity. So just as a bit of an outline for tonight, a bit of a welcome and opening. There'll be a chance for us to meet our team of Alivia GPs and our exercise physiologists and dietitians. We'll be looking then, we'll spend about 20 minutes just going through a little bit of information about menopause and weight control. So this is an opportunity for me to share my knowledge and information with you. And then around 8 o'clock, I really want you to be thinking throughout the talk, what are the questions that I want answered? Here's your chance. You've got me. I'm all yours. And I'd love to answer any questions that you have around how to best manage weight and the changes that are happening in your body around this time. And towards the end, we'll have a chance to just provide some feedback and finish up for the night about 8:30 tonight. But if the questions are good and we've just got lots of things happening, I'm happy to stay a little longer as well. Just a couple of things at the start. I love to see your faces, so please feel free to leave your video on, but I would ask that if you mute yourself, that just allows us to be not distracted by any other little noises that are happening around you, and you can eat your dinner and have your cup of tea beside you, and it's not a problem. Also, pop your questions in the chat, and then that way towards the 8 o'clock time, I'll be able to start covering off on some of those questions. But I will reserve those answering those questions for that part so that we can get through nice and quickly tonight. All right, so let's meet the Alivia team. So they're not here tonight. They're probably all tucked up in bed or feeding their families. But here's our one-turner doctors. So we've got the lovely Janelle Francis, Dr. Julie Chang, Dr. Andrea Ryan, Dr. Nicolette Scapers, myself, and Dr. Charmaine Tay, and Dr. Neha as well. So I'll show you her in a moment. Then at East Melbourne, we've got Dr. Ella Barclay, our one and only, look at that. There's a bit of testosterone amongst some estrogen. So we've got our one and only male GP there, Dr. Ankit Gupta, who's a lovely, amazing human being. Dr. Emily McMullen, Dr. Hilda Jessup, who's also at Caulfield, Dr. Tamsin Rhodes, Dr. Jane Doyle. And in Adelaide, we have Dr. Belinda Jennings. Neha's there. She joins us in one turner. And we're lucky enough now to have our very own dietitian, Rachel Davies, who's very experienced in weight management. She's done some surgical and non-surgical weight loss. She's experienced in eating disorders and binge eating and health promotion as well. So we're really excited to have her with us. And Holly Eckhart, who's our exercise physiologist. So that is our big and growing team that we've grown to over the last 4 years. And it's an amazing bunch of people who are beautifully supported by our admin team. As I mentioned, we're in East Melbourne, Caulfield, Wantirna, and Goodwood in Adelaide. So let's get to the business, which is, I really wanted to talk tonight around what is happening to our bodies around the time of menopause. So just for a little bit of information, just to sort of set the scene. As females, we know that we've got those female hormones of estrogen and progesterone. Estrogen is a hormone that acts all over the body. So it's what makes us female. It makes our girly bits girly. So it contributes to breast development, to the health of the uterus, the cervix. It also acts on other areas like our bones, our muscles, and our heart. So estrogen acts all over the body. And progesterone is our other female hormone. And that's a hormone that's only released if we're ovulating. And if you think about the word progesterone, progestation, it's about preparing the body for a pregnancy. So it makes the lining of the uterus fluffy, ready for implantation. And it's what surges in the second half of that cycle, of our menstrual cycle, and can contribute to some of the symptoms of sore breasts, bloating, hunger and cravings, etc. Now, although we're female, we've still got some testosterone, and our male counterparts also have estrogen. So testosterone is still active in females' bodies, and that contributes to our sexual health, libido, mood, well-being, and those aspects as well. Now, our hormones change dramatically throughout our life cycle. So it's all very quiet in the first 8 to 10 years. And then bang, hello, puberty. And we get this surge of hormones, and it just contributes. If you think about, what's happening for a young woman when she hits puberty, all these things that are sort of foreign to her. So there's the mood swings that occur, breast development, and changes in her body that she's seeing. So it's a time that's of hormonal chaos. And as we'll see, it's a little bit of hormonal chaos at the end of our menstrual cycles as well. And then, throughout puberty, we're getting some periods without ovulating, and they might be heavy and a bit irregular. And then they settle into this nice pattern in our menstrual years. Pregnancy is another time of hormonal surges, so particularly with estrogen, and followed by childbirth, where we have hormones that act to help with breastfeeding and the delivery of the child, of course. And then things go back to our normal cycles once again. And then around sort of from 40 to 45 years of age and onwards is the times where things start winding down a little bit as well. So, and I'll show you a little graph of that to see what that looks like. And then menopause is technically 12 months since the time of our last menstrual cycle, and then on to postmenopause. And if you think about it, we spent the first 8 to 10 years in sort of hormonal quiescence, but then we're spending, after 50 or so years of age, we're spending about a third to a half of our life in hormonal quiescence as well. So that's significant, and we'll talk about why in a moment. So we did start up here with about, well, actually at birth, we had about 1 million eggs in our ovaries. By puberty, that's down to around 300,000. And then throughout our menstrual years, we're having around 450 to 500 menstrual cycles on average. And then the quality and number of those eggs that are released from about 40 years of age onward diminishes rapidly, which is why we're most fertile in that sort of 20 to 40 year age gap. So here's what's happening to our hormones along the way. So as we said, very quiet in childhood. Then puberty, we start to see estrogen is rising first, followed by when our menstrual cycles start. That's when we start to get these surges in progesterone. And as you can see here, the surges are occurring in line with ovulation. Now, here's where things start to change. So if we think about that sort of 40 to 45 years of age, things are winding back a little bit. So what happens is the egg quality is diminishing, the number of eggs that are getting released is diminishing. And so the brain tries to control the ovaries, and it says, come on, let's go, come on, let's keep, it's like flogging a dead horse, come on, keep pumping out those eggs. And so actually we get a rise in our estrogen because our brain's trying to control the ovaries and say, come on, keep going. Sometimes we're going to ovulate, sometimes we won't, and that can lead to heavier periods because it takes time, like the lining of the uterus builds up, and if we don't ovulate properly, then we don't shed that lining. So we can get heavier periods, longer periods, shorter periods, more irregular periods, and then technically menopause hits when it's been 12 months since we've had our last period, our last menstrual period. And then we enter the postmenopausal years. So as I mentioned, that perimenopause time, that can last for around 4 to 6 years, but as short as 1 year, can go on for as long as 10 years. And we call that the time of hormonal chaos. So this is when things are up and down and all over the place. We can get wide fluctuations in estrogen and progesterone, and that can result in some of these symptoms. Some of these symptoms are a result of those estrogen surges, so things like sore breasts. Others are a result of a lack of estrogen, such as dry vagina, difficulty with intercourse, painful intercourse. There's a gradual decline in our male hormones, so we might experience a loss of sex drive and libido, which may not be a bother to you, but maybe it is to your partner. Mood swings. So this can be a time where, patients may experience anxiety or depression for the first time, or it might be a recurrence of their, postnatal depression that they're seeing. There might be changes in their skin and hair. The hair gets a little bit more coarse, and we're seeing hair in strange places. Headaches and migraines. And sometimes this perimenopause time can be the first time that we're seeing high blood pressure, high cholesterol. And what are we most worried about? More difficulty with losing weight. Menopause, that is the time of the last period. So if you think about that word meno, meaning month, pause, that means the pausing of our monthlies, okay? So technically it's 12 months since the last period, but of course, you're not going to know that until you've had 12 months since your last period. So you might think that you're through, you're like, hooray, they're done. And then 9 months later, you've got this period and you're like, I thought I was done. Technically, you're not. You're in that perimenopause time still. Now, on average, women enter menopause, have that menopause. It can be 45 to 55 years of age. That's considered normal, but the average is about 51 to 52 years of age, okay? There's a couple of situations would say that early menopause is between that 41 to 45 years of age, and premature menopause is when that menopause occurs at 40 or less. Now, that's a health concern because if you don't have estrogen for we might be talking about 2/3 of your life now, that has an effect, as we'll discuss soon, on our bone and our heart health, and we need to address this early on. So it's not normal to have that deprivation of estrogen for that long in your life, and we do need to think about some health screening issues there. Now, a lot of women will come to me and say, I need a blood test to know whether I've gone through menopause. Now, if we go back a slide or two, if you think about this, if we're doing blood tests, we might be doing a blood test here where everything looks like your hormones are A-OK, or we might be doing it down here where your hormone levels are low. So this is not a steady state level. And doing a hormone blood test does not provide any information that changes. It doesn't diagnose menopause. It doesn't help manage or treat menopause or perimenopause. So the only time we really find hormone tests useful are when we're trying to diagnose premature menopause. So if periods have become, irregular or stopped, around that sort of 45 years or less, that's when a hormone test might be useful. So yeah, that's just important to keep in mind. We treat the person, we take a good history, and we talk about your menstrual periods, what symptoms you're experiencing, and that's what guides our management. We treat you, the person, not your hormones, because that's like depends on when we're catching you for that blood test. All right, so let's have a think about why weight loss is hard around this time. So we do have a lot of women who come to us saying, I'm not doing anything different, but I just keep putting weight on. Or what worked does no longer work anymore. I used to be able to just, tighten up my diet, do a little bit of exercise, but that's not working and I can't shift the weight. Or my body's not my own, it's just not doing it, it's doing its own thing. So it just might feel like it's not in your control anymore. Or the clothes are no longer fitting and you're wanting to feel, lovely when you're going to work and fit into your professional clothes, and that's changing. Or there's just a general sense of frustration that things are changing and your body might be behaving in ways that you're not really pleased about. By the way, that's all normal. So what is the average weight changes that we see around perimenopause and menopause? So on average, it can be around 2 kilos, but it might be that there's no weight change, or it might be 7 or 10 kilos. With the slowing of our metabolism that we see around this time as well, it's normal to be putting on about 0.5 kilo per year between the ages of 45 and 55. So yeah, we are talking about that up to 5 kilos of weight loss. Now, that's very variable depending on what's happening in a person's life and other stressors, whether we're going through a global pandemic. But what makes it tricky is if you've already struggled with weight prior to menopause, because sometimes it feels like, well, that's going to be the death knell. I've already struggled with weight and then menopause is going to come along and it's going to be all the harder. But the good news is that weight gain is not inevitable at this time, and it is possible to manage your weight in a healthy way if you're conscious about what's going on. And that's what I wanted to go through with you tonight. So let's think about why we have weight gain. Now, a lot of women will come in saying it's my hormones and that's the reason, and that's part of it, but it's not all of it. The major reason we struggle with weight is because it depends on our genetics that we've inherited from our family. So 40 to 70% of an individual's weight is going to be determined by the genes that they've inherited from their family. And that's going to determine things like how hungry you feel, how full you're feeling after a meal, how much movement you do, fidgeting. It's going to affect your hunger and your cravings, whether you're a carb, whether you love carbs, bread, pasta, whether you find it hard to stop after this much or this much. So our genetics that we're born with are the biggest thing that determine our weight, and they determine our weight trajectory. And it's normal for us to gradually put on weight over time as we become less active and just with the changes that happen in our body. So if we think about what are the hormonal effects that are happening that also contribute to weight at this time, it's things like the studies show that around menopause, we actually have a temporary increase in energy consumption. So we're a bit hungrier at this time. That's temporary, normally lasts about a year. Then there's a slowing of metabolism, and that's persistent. So we see that our body just becomes a little less active, there's less fidgeting, less movement, and we see that slowing of our metabolism. It's also natural that after menopause that we have a loss of muscle mass. So remember how I talked about estrogen acting on all areas of the body? It's acting on your muscles and your bones as well. So that process of converting muscle mass to fat mass is called sarcopenia. And that's something that we can be proactive about and try and counteract with exercise and strength building activities. And also there's a shift in our weight and where we carry it, less around the hips and thighs and buttocks and more towards the center, which is not always fun either. So what influences where we carry our weight? Mostly it's because we have this really big drop in estrogen. So we have, estrogen sits around 400 in our premenopausal time, and then postmenopause it's down to 20. And so we get this relative increase in our male hormones. So we've had this, our male hormones are only sort of gradually declining, but bang, our estrogen is down here. So we've got a shift towards more, a relative increase in our male hormones. And if you think about where males carry their weight, again, it does tend to be around that central weight. The other things that can happen around menopause are we get our, this is difficult to explain, I'll do my best. The liver makes something called sex hormone binding globulin, and post-menopause that goes up, and so we also see a drop in our male hormones as well. And we also get the fat cells start converting male hormones into estrogens as well, but those estrogens are not as protective for our heart health as the ones that our ovaries make too. So we've got all these hormonal changes happening, which causes central weight, so us to carry a bit more weight around the center and around our organs. And this is not where we want to be doing it. Okay, this is the weight around our center increases our risk for heart disease, diabetes, and it's not the kind weight. Okay, so in terms of our numbers, what we see, this is the tricky thing. Around menopause, we see an increase in our risk of these things: cardiovascular risk, blood pressure starts to go up, cholesterol, diabetes, and cancer risk. All that stuff happens as we get older. But it also happens, those things go up if we've got obesity as well. So menopause and obesity kind of intersect together to increase our risk of these things. So if you have excess weight, if your BMI is above 30, your risk of diabetes goes up by 6 to 12 times. 6 if you're a male and up to 12 times if you're female. Our risk of heart disease goes up by 2 to 3 times. Our risk of blood pressure goes up by 2 to 2.5 times. Endometrial cancer or cancer of the womb, that goes up by 3 times if we have obesity as well. So that's what I'm saying, is that this is actually an opportune time to be looking at your health and managing your health risks. In other words, at this time, let's reflect and say, well, what are my risks? Have I gone and got a blood pressure check, my cholesterol checked? Have I, measured my blood sugars? Do I know my family history of those things? And where am I in my weight? And we want to focus on things that are in our control, and some things will be outside of our control. I'll just ask someone to mute themselves if they've accidentally popped off on mute. All right, so let's have a look now at how we can achieve a healthy weight. So I mentioned that weight gain is not inevitable, but it does require more conscious effort at this time. So if you did nothing with your diet and exercise, as I said before, we see a slowing of our metabolism. We're converting muscle to fat, and we've got a temporary rise in hunger. And all that will mean that if you did the same thing, you're going to gradually put on weight. So what we need to do is be focused on overcoming some of those things. So that will mean that we will need to be a bit more focused on adjusting our diet and looking at what sort of calorie level is going to be suitable at this stage in life. And that will be a change. You won't need as much food. There will be a focus on trying to build up muscle mass at this time. That means strength-based exercises, because there's a benefit of looking at weight beyond weight loss itself. It's also about how we can prevent heart disease, diabetes, and cancer risk, as I said before. Now, one of the things that we like to do here at Alivia is we do your body composition, and it's so handy because it tells us exactly what, your basal metabolic rate is. It can give you, a really accurate estimation of how many calories you burn every day. And that tells you, okay, if I want to lose weight, then I need to be having less than that. Or if I'm wanting to maintain my weight, then that's how many calories I need every day just to maintain at this time. What we love about doing our body comp is actually looking at the muscle mass, because if you've got a great muscle mass, then that's already a really positive thing. We want to track over time and make sure that you're maintaining that muscle mass, not dropping it. And if it's low, well, then that's a time to be focusing on how we can build that up with increased protein in your diet. So a protein building diet, and showing you how you can do resistance exercises to help build that muscle mass. And the great thing about that is that that's going to boost your metabolism. And if your metabolism's higher, it's easier to maintain your weight or to lose weight if that's what you need to do. So that body composition helps us in guiding what sort of dietary or exercise program is needed. But if you're looking for a weight loss of about 0.5 kilo a week, then we're looking to reduce those calories by around 500 per day. Exercise at this time is really important. Exercise is important all of your life. It's really good for every aspect of your health, but nutrition is more important for weight loss. But exercise is really important now more than ever for helping to maintain our bone health and to prevent osteoporosis as well. So you might consider around this time seeing your GP to get a bone mineral density done to see where your bone health is at this point in time. Our peak bone health actually is at age 23, and it's on a slow decline from there. But at menopause, as I said, with that drop in estrogen, that affects our bone health as well, and that can cause a drop. So you want to make sure that you're starting from a reasonable level at menopause time, and that you don't need to be, seeking treatment for osteoporosis at an early stage. So in terms of those strength exercises, things like Pilates, yoga, or just some exercises at home. On our Alivia app, we've got some really cool exercises, and Holly, the exercise physiologist, is really good at doing some home-based programs as well. But look at that, 2.5 hours a week of moderate exercises just for good health. So we're talking about half an hour, 5 days a week, or an hour of exercise, moderate exercise like walking, dancing, swimming, if you're looking for weight loss. The right dietary advice is important, and when our dietitians are seeing patients to give the right dietary advice, we're actually looking at, well, what have you done in the past, and what's worked and what hasn't worked, and what's your goal? Is it rapid weight loss that we're after, or just slow and steady weight loss? Is it really just finding out, well, what are the foods that are going to be low inflammatory foods that aren't going to aggravate hot flushes? It might be finding out more about, what do we need to be eating for weight control, or looking about, are we optimizing our calcium intake for our bone health? And also looking at our cholesterol and cardiovascular risk. So all those things go hand in hand with our eating patterns. And we also assess for binge eating and emotional eating as well. And we want to go not just from having an idea about what diet, but ideas for implementing that diet with some meal ideas too. Alcohol worsens hot flushes, one of the most common socially acceptable drugs that we have in our society. And, having a couple of glasses of wine at night can be leading to another 5, 10, 15 kilos of weight gain per year. So you just have to really think about what the caloric value is of the alcohol that you're having, and And also, is it worsening things like hot flushes? Smoking cessation is a really good time to be thinking about this too, because it contributes to those health risks and worsens menopausal symptoms as well. All right, so let's get into the business end of things and just make sure I am going a little bit over time. So I promised you I'd stay more if we have questions and if I talk too much. So if we look at what is effective for weight loss. Now, what happens is we often try and implement a lot of those lifestyle changes. So we try and reduce alcohol and get out and exercise a bit more, and we try and change our diet and, cut out junk food or reduce our portion sizes. And these are all the sort of what we call these lifestyle or behavioural changes. And that's really appropriate and often works if your BMI is in the sort of, just above the normal range. And it's important for every aspect, actually, that we look at those lifestyle changes. But the thing about weight loss is sometimes lifestyle changes are not enough. And especially around menopause, where what you were doing doesn't seem to be working anymore, that's when sometimes we need to intensify things and really get some guidance around how to find a calorie deficit that doesn't suck. So that's Dr. Andrea Ryan's sort of code word or biggest quote that I take from her. How can we help you to find a calorie deficit that doesn't suck? Because you need to find a calorie deficit to lose weight, but it has to be something that suits you, works in with your lifestyle, doesn't feel restrictive, is enjoyable, and is helping you to achieve your goals. Okay, so you still need a calorie restriction. We need to help you find that in a way that's really enjoyable. Anti-obesity medications can really be helpful in that regard, because what they do is they suppress that hunger and appetite drive, making it easier for you to choose to stick to a healthy diet and to break through where things seem to have got stuck before. So I'll go through the options of that as well. And if our BMI is at 40 and above or 35 and above, and you've got diabetes or high blood pressure or other comorbidities, then it's worth thinking about bariatric surgery, because that's the most cost-effective long-term option for weight control as well. So as I mentioned, the reason we look at going beyond just lifestyle changes, they're important, but the reason we go beyond that is because genetics is one of the biggest influences on our appetite drive and our weight. And if we're not controlling for hunger, then it's very hard to lose weight and keep it off in the long term, because the body is very smart and it wants to try and maintain things just the same. It likes homeostasis. We call it our weight set point. After losing weight, your body tries to get you right back where you were before by upping your hunger hormones, decreasing those satiety or fullness hormones. And just when you're going through menopause, if you go and try and lose some weight too, your body's going to drop your energy expenditure by 300 calories a day as well. So helpful. So all these things make it difficult to keep the weight off in the long term. So that can feel a little bit depressing, like, wow, what's the point? Why am I trying to lose weight if the body's going to fight back? But there are ways and means to kind of work around this and to get appetite suppression, either naturally through ketosis or with the help of hunger suppression or weight loss medications. So it's not all depressing, but it just does help us to understand why keeping weight off in the long term is not an easy thing. So let's have a quick look at these medications that we have available to us. So the ones that are approved for treatment of obesity in Australia is Saxenda, Duromine, Xenical, and Contrave. And I've just popped down here the cost as well as the percentage weight loss that we see with these medications in an average population. So Saxenda, that's a once daily injection. It belongs to a class of medications called GLP-1s, and these act on the brain and on the gut to increase our sense of fullness. 6 to 8% weight loss. Duromine, it's a mild stimulant, and that it works on the brain to make us feel less hungry. 6 to 10% weight loss. Xenical, not used. I've never prescribed it, not used very often at all. It stops you from absorbing fat, which of course causes fecal incontinence and oily stools, which is not fun for anyone. And Contrave is an anti-craving medication that works on the brain to decrease cravings around food, around 6% weight loss. Now, these medications are off-label for use in weight loss, but the topiramate been used for a long, long time for weight control, really cheap as a weight loss medication, and around 5% weight loss. And the ones that we've all been talking about and struggling with the shortage at the moment, semaglutide has been approved for weight loss in the States, and it's called Wegovy. We have semaglutide 1 milligram, which is called Ozempic, but semaglutide 2.4 milligrams called Wegovy, same medication, Ozempic for diabetes, Wegovy for weight loss. This medication at the higher doses was proving to show 10 to 18% weight loss. And that's why we were early adapters of using that medication in our clinic, because we had the studies and the data to back up it's a very effective medication. But of course, now there's supply issues that relate to both manufacturing overseas, where they had a quality control issue that affected their supply overseas. And there's also just a massive demand for it as well, and that's affected supply. Expected to be restored maybe by the end of August, but that's a wait and see prospect, I think. And I thought I'd let you know too that there are some emerging treatments that we may see next year. So tirzepatide is another weekly injection. It's going to be called Mounjaro, which makes me think of mangiare, or eating, the Italian word for to eat. And the weight loss that they were seeing there was 22.5%. So even more impressive weight loss than what we already have. So I guess what we're saying is there are treatment options that are readily available right now. There are ones that are in short supply, but hopefully restored pretty soon. And there's some other promising treatments that are upstream as well that we hope to see in the next year or two. All right, so I've done a lot of talking, and I'm going to stop sharing for a moment and start to take a look at the chat there. All right. So Wendy, your question was around, will we talk about hysterectomies at a younger age? So what we're talking about there is surgical menopause. So surgical menopause, if you take out just the uterus, but still leave the ovaries intact, you haven't gone through menopause. You've just removed the womb, but you're still ovulating. And so some people experience those cyclical symptoms. They might get breast tenderness or moodiness or hunger cravings, and they don't see the effect of the drop in estrogen until that time naturally happens. But they just don't have that period to let them know when that's happening. They might have to guess it from how their cyclical symptoms are going. And then there's surgical menopause, Vista, where the uterus and the ovaries are taken out. And that's the same as, that menopause is abrupt. It's like bang on, the ovaries are gone, the uterus is gone, and we're not getting the sort of, perimenopause where things just start to wind back. It's very kind of, happens abruptly. And then we suddenly see all those other menopausal symptoms that we talked about, dry vagina, a shift towards or sore breasts. We see the increase in blood pressure and cholesterol, a shift towards the more central weight. That's what happens around that surgical menopause. Sandy, you're asking, I've had a Mirena for about 18 years, so I don't know when my last period was, and I'm now 60 years old, so it's safe to have it taken out. So what I should have said at the very start is we'll be covering off general questions around menopause, but those sorts of clinical questions around your health issues should be addressed with your doctor, because in a broad forum like this, it's not the space. I don't know all of your history, etc. So I can't give you a one-on-one advice, but I can talk about general questions in relation to menopause. But what I will say about Mirenas is that a lot of women have, so this is general advice now, a lot of women have them in, just covering off until a few years past menopause or the expected menopause. That way they're getting the contraception from it, because we can still have babies until, that last egg has been released. Still possible, not likely, but possible. So contraception is important around that perimenopause time. And also the progesterone does provide a little bit of hormone replacement therapy. So some women keep it in and might use a bit of estrogen as well if they need menopausal hormone treatment, and then have that out, when they've truly think that they've gone through menopause. It might be 52 or 55. There's not much value beyond that. questions around what are the bad side effects of bariatric surgery. Thanks, Sharon. So every procedure has its side effects, and the most common surgeries would be the gastric bypass and the gastric sleeve, the sleeve being the most common. Around 70% of surgeries are a sleeve, and that's where 2/3 of the stomach is removed, leaving a small volume, high pressure pouch, a very non-stretchy part. So the risks of that are in relation to infection, the leak from that staple line, hemorrhage and bleeding, all those surgical risks. But down the track, it relates to malnutrition. So it's not as malnourishing as the gastric bypass, but there is still the risk of not absorbing iron, B12, folate. So we need to be taking a multivitamin for life if having a bariatric procedure. But those bariatric procedures are actually as safe as having your gallbladder out. So they're not high surgical risk. And the more a surgery is done, like the sleeve being very common, the lower the risk is. So it's actually not a risky procedure to have, but we need to be thinking about your bone health, about your nutrition, staying on a multivitamin for life. Reflux is one of the more common side effects with the gastric sleeve as well. Can you explain a little more about progesterone and bloating? I've been taking menopause hormone treatment for around 6 months. I've noticed I'm feeling bloated. Is this due to progesterone? Yes, progesterone is that pro-gestation hormone. It causes the breast tenderness, the bloating, constipation being one of the other ones as well. So getting the balance right in those hormones is important, and that's something that you should have a chat to your GP about, but that is going to be one of those side effects. And how long to be on HRT following a total hysterectomy, assuming that's where your ovaries have been taken out as well. It depends on, this is a very individual thing as well. So those postmenopausal hormone symptoms or perimenopausal hormone symptoms, they can last for a couple of years. But there's a small percentage of people who get those symptoms ongoing. So the doctor would weigh up with the individual what's the risks or benefits of continuing hormone treatment. And if it's quality of life and you're going bonkers without them and you're feeling really not well, then that person, there might be an argument for continuing that long term. And there are a small proportion of patients who continue on HRT long term. But that's a risk benefit discussion to have with your GP. Karen says, oh, sorry, if I missed, yeah. So Karen's asking, I'm great with food for most of the day. I get to 4 o'clock and I just want to eat everything. Is there something I can do to stop those afternoon cravings? I'm 55 and yet to hit menopause. Well done. You've got your estrogen hanging around for a long time. Go you. That's wonderful. But 4 o'clock, what that tells me is that hunger control is not fantastic. So remember how we talked about at the start, the body's actually primed for survival. Survival of the fittest means that if you're an energy storing human being, which we all are, we're all good at storing energy, but to different degrees. So people who store energy really well can struggle with obesity, and those who are energy wasters, they will be lean. So what happens is if you're an energy storer and your body is optimized for that, then you're going to have a certain number of calories that you need to reach every day. And if you don't reach that calorie level, your body actually intimately knows where your calories are at, and it will say, rightio, we've only had very few calories in the morning. I'll ramp up hunger in the afternoon to make sure we catch up for the day. So you're probably trying to do your best to have a calorie restriction, but your body is fighting back with hunger, and that's what makes weight loss hard. So part of the key there is saying, what's going to be the diet that helps me to feel more satisfied throughout the day? Maybe it's having more protein in the morning or in the lunchtime meals to kind of see you through. Maybe it's having, and that's a very common thing we see at Olivia, where we're underdone with protein intake. Maybe it is that you need appetite suppressing medication if you need that. That can be very helpful. So that's where Ozempic was wonderful, because it would kind of cover off those afternoon cravings and hunger. High fiber foods also contribute to a sense of fullness. Low GI foods as well make you feel fuller for longer. So it's got to do with, have we got enough calories coming in for the day? And if we need to reduce calories, but we're still feeling hungry despite making sure that our diet's at its best, do we need to think about weight loss medications to take care of that hunger so that we can get about losing weight in a healthy way. And the analogy I would say there is, if someone is prone to asthma, then we use a preventer to kind of help their airway, and then you do the lifestyle measures to keep that at bay. And it's the same with weight loss as well. If you're doing all the right things with your lifestyle, but you're still hungry, that's the biological part that we need to try and manage to help you to keep your weight steady. Is intermittent fasting any good for weight loss post-menopause? I'll go back to Andrea's comment. We want to help you find a calorie deficit that doesn't suck. Okay, so this comes back to it just depends on what suits you. Some people find intermittent fasting works for them because they don't naturally feel hungry in the morning, and they can get to lunchtime, have a decent meal there, do a late afternoon's high protein snack and a meal, and then fast from 8 o'clock onwards. That's great. That's a way of getting a calorie deficit because you're having less calories throughout the day. Other people find that doing a very low energy diet with meal replacement works. Other people find that doing a keto diet with regular food helps to suppress their appetite and get them the calorie deficit. So there's no one diet that's better than another. And that's what we do in that initial consultation, is to try and figure out what's the best diet for you, because that's what we need to work with the most. And that might change. Maybe you do a very low energy diet at the start, then you might move on to my favorite, high protein, low carb diets. Things like the CSI or Total Wellbeing, where you're not restricting every food group, but you're having protein that makes you feel full. You're having low GI healthy carbs, because carbs are not evil for or bad for us. But at the start, when we see patients, we might often do a little bit of a burst and do some meal replacements for a few weeks and try and get some initial runs on the board, particularly if there's a fair bit of weight to lose. Because it can be a long road otherwise if you're losing half a kilo a week and you've got 40 or 50 kilos to lose. So it depends on where you're at the start, how much weight you need to lose, and what you like doing and what's doable around your family life. So there's no cookie cutter solution. It's a case of figuring out what works best. But yeah, fasting does mimic our natural cycles a bit better. We're not meant to be eating from 7 in the morning till 11 o'clock at night, so the intermittent fasting can help regulate some of our diurnal rhythms as well. Peripheral neuropathy is not necessarily linked to menopause, so I'd be checking that out if that's a symptom that you've been experiencing. Joint aches and pains, yes. A crawly feeling under the skin, yes, but not peripheral neuropathy. That does need looking at. Sharon, with the lap banding, you're asking about lap banding as a procedure not commonly done these days, was considered to be reversible, but it's not very strong as a metabolic surgery. In other words, it's working more by that restriction, having a band around the top part of the stomach, and it shoots off some suppression of appetite signals, but not as strongly as the sleeve and the bypass, because what we're doing there is we're affecting the hormones that are driving hunger. Okay, and if you think about those medications we were talking about before, we call those bariatric surgery without the surgery, because some of those hormones like Ozempic help to mimic the same feeling as the surgery, feeling full and satisfied. Once you start a weight loss medication like Ozempic, how long does it need to be taken for? And most people go back to their pre-medication weight who've stopped. Thanks, Julie. So think about if you have a family history of blood pressure, maybe you got to 40 or 45 before blood pressure became apparent for you, and you take the medication for blood pressure for 3 months and go, I'm cured, it's done, I'm finished. Well, it doesn't work like that for blood pressure, and it doesn't work like that for weight loss either. So if we're thinking about weight gain and obesity, it's a chronic condition. You lose the weight, but the tendency to weight doesn't go away. Okay, so there's part of it that's going to be genetics, and that's when we're thinking about, do we need to use the weight loss medication long term? I like to think about, well, how much of this is genetics? Is there a strong family history? Has the person struggled with weight from a young age? Is there a large degree of weight that we've got here? Because the larger amount of weight there is to lose, the more likely you are to need to use medication long term, versus someone who might have 5 or 10 kilos to lose, that's a lot easier to get off and maintain with lifestyle change than, you know, your 40 to 50 kilos to lose. And then there's lots of things in between. So a lot of people find that that once they've got the benefit and felt like what it's like to have appetite control and how easy it makes things, they're like, don't take this away from me. And we don't. Like, you can stay on weight loss medication in the long term, depends on which ones they are, but particularly things like Ozempic, that's used long term for diabetes. And this condition of weight is a long term issue as well. So yes, it can be used in the long term. And if the studies on whether weight comes back on when you stop it show that most people do regain weight, because when you stop the medication, your appetite levels go back to what they were before. Okay, so that's why we try and find any way possible to help you to feel full and satisfied. That's why we look at keto diets at the start, because they naturally help you to feel full and satisfied, because you're using nature's own appetite suppressants on the inside, ketones. But that's hard to stick to in the long term. So it's good in the short term, but not really a long-term way of eating. High protein, low carb diets help to suppress appetite. High fiber, low GI, all those things do. Medication for those who need it, and bariatric surgery suppresses appetite in the biggest way, if that's what's needed. What effect on the body of long-term use of the very low calorie meal replacements? Good question, Ruth. So anytime you restrict your calories, your body wants to fight back and help you to regain that weight. Now, whether you do it fast or slow, so for example, if you do a VLED, very low energy diet with the meal replacements, versus just a reduced calorie diet, 1,500 calories a day, the rate of weight loss was faster with the VLED and slower with this one. But the rate of weight regain was similar in both of those groups in a study done in 2014, I think it was. So rapid weight loss does not mean rapid weight regain, but anytime you restrict your calories and try and reduce them, your body will try and slow metabolism a little bit and try and fight back with an increased hunger to help you to regain that. So that's the tricky part, is your body's not on board with, it doesn't want you to die in a famine. That's what it's trying to do. It's trying to help you to not die. So it's doing too good a job sometimes. Sue's asking about what is the difference between the sleeve and the bypass surgery. So the difference being with the gastric sleeve, we're removing 2/3 of the stomach. Now, I had a surgery slide in my slide deck, but I removed it because I didn't think people would want to know about that. Now I'm regretting my decision. So I like to show visuals with things. So with the sleeve, we're removing 2/3 of the stomach, leaving that small, banana-shaped stomach remaining, and we get food contents hitting the small intestines more quickly. So this part of the stomach that's been removed, that makes ghrelin, our appetite stimulating hormone. So you've taken away part of the body that makes hunger hormones, so you feel less hungry and you're feeling more full because food's hitting this high, small volume, high pressure pouch, and food contents are hitting the gut and more quickly sending up those signals to the brain to say, stop eating, we're full. With the bypass, what happens is you bypass, you get this small refashioned stomach. So top part of the stomach is refashioned into this small pouch. And then we get a loop of the small bowel coming up to join up to that stomach, bypassing the lower part of the stomach, and where bile enters and our pancreatic enzymes enter the small bowel. So we're bypassing a part of the very top part of our small bowel where a lot of absorption happens. That's of our nutrients. That's why the bypass results in more weight loss, but it also results in more malabsorption. So it's easier to become iron deficient, B12, folate deficient. Bone health is an issue, but it offers a greater amount of weight loss. So when talking about sleeve and bypass, the surgeons will talk about the benefits, pros and cons, both in terms of the amount of weight loss and the side effects. But that's the biggest difference is bypass, 25 to 35% weight loss, sleeve, 20 to 30% weight loss. Bypass better if you've got diabetes, because there's a more profound effect on diabetes with a greater improvement. Better is okay if you've got reflux. Whereas if you've got reflux, the sleeve's not so great because it worsens those symptoms. But on the plus side, really good amount of weight loss and less malnutrition with it as well. You guys have got great questions. What stops people staying on ketogenic way of eating, considering the benefits? Or is it that we don't actually recommend you stay on it? The thing that makes it hard, so the studies show that patients who did a keto diet can generally do it for around 6 to 12 months before waning and sort of going back to regular eating patterns. And I think it's because of the restriction. Like, it's really good when you're in ketosis, but it's like a little bit like being pregnant. You can't be a little bit pregnant. You can't really be a little bit in ketosis. You're either in or you're out. When you're in, it's great because you've got really good appetite suppression. But when you're out, then you're feeling hungry. So, and that can happen with a social function. It can happen when you go out and have a glass of wine, or, you know, if you, you know, have a little bit of carbs, have a hot cross bun or something around Easter. So all those things can make it tricky because you're trying to really be diligent with your diet all the time. And it does require you to have less than 50 to 60 grams of carbohydrates per day in order to be in ketosis. So that's the tricky part. But if you can stay, if there are a small proportion of people who do stay in a keto diet, there's no real downsides. There's a theoretical risk because you're in a mild acidic state that you could leach a little bit of calcium from the bones, but that's not proven to be of a long-term health consequence. We haven't seen massive amounts of osteoporosis as a result, but yeah, it improves concentration, energy, appetite suppression. The cardiovascular benefits are really good too. So yeah, it's a good way if you can stick to it. So Sue's asking a question, would bypass be recommended for a person with celiac disease? That's a tricky one because it depends on how well that celiac is controlled, and because often we can have secondary malabsorption or secondary nutrient deficiencies because of the gut being inflamed, if there's an excess of gluten in the diet. But if it's well controlled, there's no reason that it couldn't be done. It would just mean that there would be more attention paid to nutrients and making sure that you're not nutrient deficient. And Sharon's interested to know, if your body's just going to go back to its original weight, what do we do if we don't want to stay on medication forever? And I think your questions earlier, Sharon, might have already answered that. Bariatric surgery is the most long-term effective way to keep a significant amount of weight off in the long term. But as I showed you too, we've now got treatments coming up that are like tirzepatide, which might be offering the same amount of weight loss as bariatric surgery, but without having to undergo surgery. So the trade-offs then are, do I need to be on, you know, weight loss medications, which the thing that's hardest and the thing that hits our heart the hardest is that all these weight loss medications, they're private script, nothing subsidized under the PBS yet. We've had Ozempic go forward for the treatment of obesity under the PBS, knocked back in March. We're going to continue to try and fight for that on your behalf. But I think it also shows that this condition is seen to be someone's fault rather than being recognised as the true, you know, health disease or condition that it is. And obesity is being recognised by the World Health Organization as a chronic disease. So until governments start recognising it as a chronic disease and not blaming people for it, it's going to be hard to see those things being subsidised. I digress. You're asking about surgery. I am hopeful that we will see other treatments become available that are as effective as surgery. But yes, it's either long-term medication, or the trade-off would be a more invasive procedure, but really good long-term data on that. Now, I just wanted to share something with you as well, because we are a little bit excited at Alivia, because last year we did a survey of our patients because we like to find out what you want and need. And we've been busy behind the scenes, very busy, little busy beavers, creating a new booster program, because one of the things that patients said is that they really would like to have a period where they can get some intensive help with weight loss. We know it's a chronic disease. We know that you're going to need that support in the long term. but we've created a 12-week program for patients that are wanting to get some rapid weight loss, have the accountability of seeing somebody weekly via telehealth or face-to-face. And we've got 7 sessions with a bariatric GP, 3 sessions with a dietitian, and 2 with an exercise physiologist to help our patients or any new patients to be able to really see some rapid weight loss. So I guess if you're thinking about tonight's topic, menopause is a common time that women get stuck in their weight as well and want to sort of break through. It's got Medicare rebates available, the body composition. There's 2 body comps included in that, one at the start and one at the end, so we can see what our progress is, and access to the Alivia app, of course. The cost of it, we've broken it down into the sort of monthly and 3 months. So it's a 3-month program. The out-of-pocket costs, I'll show you over here, $542 or $6 a day. Or $181 a month is your total out-of-pocket after your Medicare rebates. It can be paid in upfront or in monthly instalments as well. So, and then you get your rebate back when you see the doctor or the dietitian, etc. And actually, the other thing is that if you've reached the Medicare safety net and you're getting 80% back on your Medicare rebates, it could be as low as $1 a day. So that's a really good time to be looking at that if you're keen to. And it's also 20% off if you compare that to our regular consultations as well, with the way we've packaged them together. So it's not for everyone. Oh, look at my thing. I just need to, I'll just go back and screen share that, but my little thing goes across the front. So who's it for? It's for people who want to shift some weight. You want to learn how to keep it off, or if you're struggling with that sort of menopausal weight. But it's not for people who want a quick fix and think that it's just a magic pill and that's as quick as, you know, it's easy. It's for people who are committed because it is 12 weeks. So it's not for, you know, oh, I'll just have a little dabble and see if it's for me. It's if you're serious about getting some weight off and you want that one-on-one support from a medical team, that's us. And but we're only doing it as a very limited program at the moment because it's just a one-off, and we want to make sure that we're giving that one-on-one care to each of the patients that are going through. So there's 4 doctors that are offering it and 5 spots per doctor, and we're kicking off in 2.5 weeks. So if that sounds like something that's of interest to you, feel free to just scan the little QR code here with your phone. And that'll lead you to our Alivia website that's got some more information about that. Or you can just drop a little thing into the chat and I can get in touch with you as well. And Ray, your question is, if I have a chronic healthcare plan, is that considered with the dietitian? Yes. So you can get rebates. The way we've factored in with that costing there is that it is with a GP management plan where you get $55 off with a care plan. But also some patients have got some really good health insurance with extras, and that might cover the cost as well. Thanks, Sue. I'll be in touch with you. Yeah, so there's some more information up there on the website, and we're really excited about this. But tonight's purpose is really about giving information that's relevant for you, and that's just something that's kind of come to the fore in the last. We've been working on it for the last month and a half. So great, thank you, Sharon and Marie. I'll be in contact with some more information. But yeah, I'm really keen if you've got any other questions. To open up the floor again for any other questions that you might have. And we're going to do more of these talks as well. So I'd really be keen to hear. I really like answering. It's a great way to provide a lot of information at once to a bigger group of people. We've always got our one-on-one consultations with each of you. But if you've got topics that you'd like to hear about as well, I'm really happy to do some educational talks on things that are of interest to you, and just, yeah, stepping outside of your families and consult rooms, we can do that as well. Yeah, lockdown menopause have not been kind to you. Kelly, medication, really good question, is medication in addition to the cost? So we've applied as a group to be suppliers of medication, so act as a pharmacy. That's not available just yet. And so also I had factored in costing in some medication too, but some people will be on topiramate at $17 a month. Others will be on Saxenda at $387 a month. Most will be on Ozempic when it's available again, but it's not available at the moment. So this round, we won't be including the medication as part of it because that's going to vary from person to person. But in the future, we will. We'll make that cheaper than if you were seeing a pharmacy and convenient because you can just pick it up from us as well. Great. Yeah, menu planning, Pauline. So, Pauline, you were wanting that as a bit of a topic, you mean? Yeah, great. Okay, that'd be great. Maybe we'll get Rachel offering that as a session as well. I've been thinking that as well, just even, basics on making salads, how to make variations on different salads and meal planning, getting some basic ideas going and adding in different recipes each week. Great. So I'm just going back up. Sorry, just going back up. There's a little question there from Lisa. The forum is great for a few reasons, such as others may ask things you're thinking. Great way to share information. Ideas come up. So many benefits of listening to and sharing queries. Thanks, Lisa. I like it too. Thank you, Sandy. Great. Great. Oh, great, Sharon. I'm pleased to hear that. Excellent. Thanks, Claire. Good on you, Claire. I'm really pleased to see you're motivated to keep going. Well done. Okay, so Ray, your questions around info around celiac, food allergies, IBS, and meal planning. I think that's a great topic as well. Yeah, wonderful. And don't forget, you don't just drop things in the chat here. Send us a message, pick up the phone and call reception. So yeah, anything that you need. We really, one of our focuses this year at Alivia is about providing you with more of what you wanted. And so to that end, this has been the biggest part has been getting this prepared. We've got the booster program. We've also got now our in-house dietitian. We're going to be building some more meal plans into our app as well. So we've got a bit more of a variety of meal plans and some app improvements are coming as well. I'm very excited about that. We've got a whole upgrade around our app. We've got some mindfulness resources that have been built, already done, just waiting to be uploaded as well. So we've got quite a few more things coming your way as well. Thank you, Lisa and Lisa. Wonderful. All righty. Well, thanks everyone for your time tonight, and we look forward to catching up with you again soon. Alivia doctors are there to help and support you if you need. Really keen to have a chat to those who are interested in the booster program as well. We're really excited about kicking off with that, and we'll provide you with a load of information, some goal setting, what each of the sessions involves as well. I'll send that along to you, and yeah, looking forward to seeing you soon. All right, wonderful. Take care, everyone.